Good morning. This morning I'd like to talk about advanced maternal age and IVF. What does the data show? This video was prompted by a recent publication in the Human Reproduction Updates journal by some Canadian authors, published in August 2025, a meta-analysis and systematic review of advanced maternal age patients in IVF. And by way of a spoiler alert, the findings of this paper the wider implications were that this review failed to find an advantage to the routine implementation of treatment strategies such as specific stimulation protocols, organotrophins, ICSI, and PGT-A, and a potential harmful effect of assisted hatching. Made the comment, future high-quality randomized controlled trials are needed to affirm the majority of this review's conclusions. This article is not open access and requires a subscription to read it, but it is recommended. So as they say, advanced maternal age patients pose challenges related mainly to ovarian reserve, oocyte quality, and high miscarriage rates, reflective of the higher aneuploidy rates with increased maternal age. And they focus their attention on several points: the definitions, the ovarian stimulation regimes, ICSI, artificial hatching, duration of embryo culture, the number of embryos transferred, pre-implantation genetic transfer by aneuploidy testing, and interventions. But by way of welcome and a disclaimer, my name's James Danger, and I'm an embryologist with more than 50 years experience. These videos bridge the gap between, I'll just move that up there, that's better. Bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. As always, I allocate this page to a supporter of IVF Daily. I'm just starting out, but if you want to promote your company or clinical product, this may be just the place. In supporting FertAid's IVF Daily channel, your support may mean an IVF client becoming a better informed client. You can click subscribe or become a sponsor or just make a donation to help others on their fertility journey. Now, women in advanced maternal age are not new. Even in 2007, Norma Gleicher was talking about is how too old for IVF. Are we discriminating against older women? And you can see here the proportion of older women are increasing in the total pool, increased from 37% for the under 35s to more than 60 to 80% for the over 40s. And he reports in that paper, women at ages 40 to 45 in the US, and this is in 2007, almost 20 years ago, represent the most rapidly growing age group through going through pregnancy. Together with the demographic fact that the last vestiges, the large baby boomer generation, are now aging beyond their reproductive life, this observation points towards increasing demand for IVF at advanced female ages, as indeed has been observed in the last few years. And then they make a very valid point. A shift towards older patients in IVF programs can also be expected from improving pregnancy rates. As a consequence of quick pregnancy success in younger women, the more difficult cases, such as older patients, remain disproportionately in the system, while younger patients are quickly discharged. So, what is an older, mature age client? First off, I'd like to apologise for this cartoon, which may cause offence, so I do apologise. But in reality, a discussion about mature age and IVF is always a very delicate subject. Traditionally, advanced mature age clients have been defined in medical literature as maternal age is 35 and above. This definition stems from the observed decrease in population-based birth rates starting at 35, and various studies of the conclusion of declined fertility with increased maternal age has been repeatedly validated, both in general and in subfertile populations. But over 40 is a more common divider, with 36 to 39 seen as that transition age. May I point out, though, that over 45 is often considered the upper limit for treatment, while most clinics may report the occasional pregnancy between 45 and 50. many of which are miscarried. I've also had a case about 20 years ago where we had a 49-year-old lady deliver a child, but she lied about her age to overcome our upper limit for treatment. Go figure. Okay, just a few more points about maternal age. The graph here shows the exponential rise in IVF babies being born each year. And if in 2018, when the last data was collected, 1.4 million babies had born, that represents probably in the order of around about 10 million cycles. Because there are a number of different ways the authors can define maternal age, it makes many studies difficult to process. Also, clinics may vary how they offer a variety of treatments based on age and the number of previous treatment cycles. But I'd like to make the point, with each intervention requires more time and resources by clinics, increasing the cost and the risk. And as a proportion of AMA clients increase, so does the cost and the risk. But there are other ways you can look about mature age, not so much in age, but by their ovarian reserve, look at the anti-Müllerian hormone level, antral follicle count, and some groups have tried to define them based on prior history into a classification called a Poseidon classifications, and 3 and 4 will be seen to be associated with poor ovarian reserve. So here's a paper posted in 2019 on management strategies for poor responders group, which are not necessarily the same as mature age people. But once again, they're using all these different criteria and the management strategies, etc. And it's based really upon the antral follicle count, AMH, and previous cycles, number of eggs recovered. So this is a different way to address mature age, but it is focused more on ovarian reserve than just straight age. But this is not the focus for this publication, which looked at age. Any review using the Poseidon criteria may well differ from that based in this report, but like this review, we have no idea whether these options actually deliver a better outcome. So let's look at a couple of things. Most of their focus was on stimulation, and they make a couple of quick points. They observed that in some studies they looked at 3 to 4 IVF cycles may result in improved birth rates, but a delay in IVF initiation of a year or two does not seem to hamper the results. So you might make a point here that for a younger couple in their late 20s or early 30s, they may achieve a pregnancy within 1 to 2 cycles, but for women in their 40s, they may require 3 to 4 to 5. So in some way, it's about an expectation and setting your limits to your management. They could find no benefit for adding things to stimulate follicle recruitment, such as androgens like dehydroepiandrosterone, but they could find potential benefit for long GnRH agonist protocols over the shorter protocols. And this may be that with the agonist protocols, there is a rise in LH at the start when the agonist is given, then there's that a long time to allow for follicles to be recruited. They couldn't find any benefit in natural cycles or progesterone priming. But overall, there does not appear to be any clear advantage to any medication, any FSH medication for advanced mature age clients. Similarly, they went through and looked at the addition of giving extra LH, which is involved in recruitment, while FSH is involved in follicle maturation. LH is involved in recruitment, and they could find no evidence to support that. They could find some benefit of using growth hormone. Quality was low, and I have been involved in some of those studies, and there may be some patients that may benefit from considering it. They also made the point there's a possible benefit using a dual trigger at ovulation, which involves giving both an agonist and HCG trigger, suggesting that some aspect of the ovulation induction process, which is associated with the potential of the oocyte to be aneuploidy, may have some benefit. So some of the options you can discuss with your doctor. They could find no benefit from a freeze-all approach. This is the philosophy where they thought you might collect 1 or 2 eggs, embryos, freeze them down, have another cycle, have 2 or 3 cycles, collect a whole lot of embryos together and do one big transfer. Nor they could find any evidence to support a specific frozen embryo transfer protocol. Natural cycles or artificial cycles. They could see some potential benefit to the same month of double stimulation to the one cycle. That's where you have one cycle do a pickup and start straight away. But once again, I think this aims to double up doesn't seem to be particularly effective. For sperm microinjection, a lot of clinics use ICSI rather than IVF because there's low numbers of eggs and they really do want to make sure they don't have failed fertilization. But when you're going back and look at the data, the meta-analysis comparing IVF and ICSI for non-male factor cases, then no one can find any advantage of using ICSI for advanced age patients, and there may actually be some harmful effects when there are low numbers of eggs. And also assisted hatching. This is where you make a hole in the capsule surrounding the eggs to allow the embryo to hatch out and to stop it from being entrapped. And the authors here report from a number of meta-analyses a potential reduction in live birth rates with routine implementation of assisted hatching. These are fairly low quality evidence, but does require some justification from your clinician. The authors looked at whether you should put embryos back at cleavage stage, day 3, or blastocyst, and they found that there was one large randomized trial suggesting a benefit for growing embryos out to day 5. This is the blastocyst stage up here. And it's all been supported by several low-level studies. But I'd just like to make the point here that it depends on how you calculate the data. Growing embryos out to day 5, particularly for mature age people, involves considerable risk that your embryos in culture may not develop the blastocyst and your transfer may be cancelled. Therefore, calculating pregnancy rates based on transfer may be misleading because for day 5, about 10 to 20% of cases are cancelled. And comparing the number of embryos transferred, in summary, one reasonably high-quality randomized controlled trial suggested that putting more embryos back resulted in an increase in birth rate, but an increase in risk of multiple pregnancies. And that's a clinical decision between your doctor about the risk of multiple pregnancies on maternal health. And lastly, looking at pre-implantation genetic diagnosis for aneuploidy, the authors looked at a similar birth rates for both PGT-A and no testing. So several trials did suggest a potential reduction in the number of transfers needed to achieve live birth with PGT-A, and also a minority report on the reduction of miscarriages. I think that the evidence is fairly strong that PGT-A does produce around about a 50% reduction in miscarriage rates. But if you have 3 embryos and you put one back, you test them and one is normal and 2 are abnormal, you put the good one back and discard the others, you have 1 chance of pregnancy. But if you put all 3 embryos back not knowing if they're normal or abnormal, then you're still going to get the same pregnancy rate. So the cumulative pregnancy rate is the same, but using PGT-A, you run the risk of not having transfer, but if you do have a transfer, there is a higher probability of pregnancy. They looked at several other interventions which they didn't really go into. But one thing they mentioned was sperm donation, which is always an option, but rarely in these cases is rarely is the sperm the main problem. You can make a comment that if you have a client who is mature age, it's almost certainly their partner is going to be mature age as well. One of the greatest interventions they could have talked about was donor oocytes instead of using their own eggs. This addresses the core issue of increasing the low oocyte yields and decreasing capability. This wasn't addressed in this review. So just to summarise the outcomes, 1,251 studies were included in the review. They found AMA was not always defined in all the studies. That's causing some problem of how you do your meta-analysis. But for the majority of the evidence, there appears to be no clear advantage to any stimulation protocol in mature age patients. Maybe long agonist cycles with dual ovulation induction were the only highlights there. There appear to be no advantage in any specific FSH medication, while an analysis performed with the addition of luteinizing hormone demonstrated a similar pregnancy rate and live birth, that is, no extra gain. There was no good evidence to be found to support routine implementation of ICSI, while a meta-analysis performed for assisted hatching pointed to decreased live birth rates. There is low quality evidence demonstrated an increase in live birth rates with multiple embryos transferred, but also with an increase in multiple pregnancy. Finally, a meta-analysis performed on pre-implantation genetic testing for aneuploidy pointed to similar live birth rates as in not doing the testing at all. So in conclusion, while the treatment of mature age patients in IVF involves challenges and often diminished success rates, this review failed to find an advantage to the routine implementation of treatment strategies, such as specific stimulation protocols, gonadotrophins, ICSI, and PGT-A, and the potential harmful effects of routine assisted hatching. The authors make the comment that we urge clinicians to consider the risk profiles and the lack of long-term data associated with each intervention, the financial burden imposed on the patient, and the workload necessitated from the laboratory staff. But I'd just like to make a few comments on myself. I believe there is a genuine desire for all clinics to provide the best treatment. Each new treatment may involve a different option purely to provide the clients with a sense that they are trying something new or trying everything. In this context, even if the new option may not be beneficial over all cases, each client is an individual case where maybe the treatment may be applicable or appropriate. So one of the downsides of using a global meta-analysis type approach is that it assumes everyone is the same, but of course everyone has their own circumstances, and any one particular treatment may be worth the option of trying. Often, the new options may involve additional costs and risks, and this is a personal decision taken with informed consent. With counselling, most clients will set goals and parameters to achieve their treatment, put limits on it. There is some concern, though, that these add-on treatment options may be excessively promoted for commercial gain. Many involve considerable more work for clinic staff. Sometimes the best option is just to repeat attempts and transfers with minimal interventions, but with limits before saying enough is enough. And finally, I need to say this review may seem negative since most add-on appear not to stand rigorous analysis, but we've seen enough dreams to coming true and lots of dreams that haven't. I'd like to thank you for your attention.